We saw it before, the clonal heterogeneity of the disease is probably going to show this type of pattern, and we may show different curves, but more and more I think people are living longer, but to some extent the relapse, at least this is my experience, I don't have data in the clinic, the relapse may even arrive after 10 years, and I will show some of the data we have where honestly, this is what seems to be the case. First issue is this one. Never forget it. We started 1998 with a median survival of 29 months, including younger patients. Today, we are talking about 7 years, 6 for the elderly, approaching 8, 9 for the younger. So this is a huge improvement. It was not so in many other diseases. And Barloghi could say these are the cure patients. Unfortunately, here there are 20 patients, more or less, and we are only at 5 years. Later on, this is going down. But anyway, beside this, what I want to make the point here is that in terms of possibly reaching the cure, but more importantly, going to 10 or 15 years of survival, we have to have very clear, in my opinion, few concepts. The first stratification is that early is better than late intervention. I'm not going in detail. The disease is going through different genetic mutation, but the end point is that with time, we have an acquisition of a different genetic mutation, and the disease is becoming more resistant. This is the usual slide, but please remember that at diagnosis, PFS today, 67% at 5 years means around 6 to 7 years. That is not something trivial. Here, the PFS is 4 or 5 months. So the first concept, not so clear in the clinic often, because in the clinic often you say, well, maybe I wait for the next relapse, is that if you want to play the game must be played immediately, because immediately the disease is sensitive. And you can see it here. We already showed this slide. There is some discussion, early versus late transplant, no question. I have to make a disclosure here. There is a survival advantage. These are early data, but we have an update with a survival advantage for the autologous transplantation versus the. Another issue that is coming, and is probably relevant in terms of saying that early is better than late to improve our outcome, is to include new criteria, because today now we wait for the crab when we start the treatment, probably to be more sophisticated and early on start the treatment in newly diagnosed patients. Plasma cell more than 50%, free light ratio more than 100, more than 1 focal lesion, MRI of low dose CT scan. This is another concept of early that might significantly improve the outcome. We probably today wait too much before starting treatment. An earlier approach might significantly improve the outcome. The Mariví Mateos study, beside the discussion of smoldering or not, is clearly showing that if you approach the disease earlier, the advantage is quite significant. Then there is another issue, and we should probably stop saying that we have standard, high risk. We have different diseases. And I do understand the concept that I would like to have a biomarker to say that there is a BRAF mutation that makes myeloma 1-2B. Unfortunately, we are not at that stage, but already today, I think we have to acknowledge that if you have an ISS3 plus one of those alterations, you have 2 years. And this is a completely different disease from a low-risk ISS1 without abnormalities, more than 10 years of overall survival. But here there is another message for the community. We are intensifying the high risk, 2 years, and we are de-intensifying the standard risk, losing probably a major advantage. Sagar would say cure, but I would say losing probably a major advantage in patients with the most sensitive disease. So you intensify at 2 years and you move to 2.5. You de-intensify in the standard 6, and from 10 you move to 5. This is the damage we are probably currently seeing today, because de-intensifying the sensitive disease, the standard risk, Sagar will say we are reaching cure. I'm saying we are damaging the outcome of those low-risk patients. These are the curves. Another issue is stratification for response. This is another good way where we can create a major damage in many patients, because as Sagar mentioned, CR are not the same, and you can see here, these are all patients in CR. Also, this one are all patients in CR, but these patients are doing completely differently from the other. But someone would say to stop after 4 courses because we reach a CR. And that's the damage is ongoing in the clinic, because at that patient, you might not give transplant because he's in CR already. And that patient, instead of having this outcome, might be going to this outcome. Why? Simply because, and this is our fault, I always say it, we still call it CR, what is not CR. And you can see it here, and I completely agree with Sagar from this point of view, that this is what we define immunofixation negative CR. Within that immunofixation negative CR, you might have this level of this level. And I would like to give you a couple of numbers. Serum is able to evaluate 10 at -2. Flow is able to evaluate 10 at -4. Molecular CR is able to evaluate 10 at -6. And we currently say with the 10 at -2, 1%, we have a CR. Of course it's not. But in that CR, we stop treatment, create another, I would say, clinical damage. Stratification for risk factor, very quickly. If we get a major improvement today, is in the sensitive disease, is in the standard disease. The high risk has been moving not enough, very slowly. If we double, if we move from 5 to 10 years in the standard risk, we move from 2 years to 2.5 in the high risk patient. These are different studies, but I don't want to go. And of course, there is an issue that has been touched, and I completely agree with Sagar. We have to move to new tools. We need a better definition of CR. We will discuss if flow is better than molecular or vice versa. Molecular is certainly more sensitive than flow. Flow is more easy to perform. But I would like to also acknowledge that, and I'm probably from this point of view slightly in contrast with Sagar. You say here the concept is very simple. Do we have lymphoma or do we have leukemia? Because if we do have leukemia, we do the bone marrow, everything is finished. If we have lymphoma, you have a negative lymphoma with a positive lymph nodes. And that's exactly the story of myeloma. I tend to believe that with very sensitive methods of MRD detection, the positive PET will be only present in 10–15% of patients, therefore a minority. I know there have been studied PET positive or negative, but these were not done with true MRD negative patients. I think myeloma is in the middle, but I would bet for 85% leukemia versus 15% lymphoma. These are the scheme. I'm not going because it's been already basically discussed. If we want to cure something, certainly we need induction, we need the transplant, we need the consolidation, we need the maintenance. But look here, and that's why MRD is important. If you start to look at the MRD level, you see 3 types of patients. You see one patient that doesn't change anything, is really in plateau, at least at the MRD level. You see the third patient that is slowly starting to grow, even in 3 years, without sign of relapse. And you see a third type of patient that might go down in terms of MRD after 3 years. So here again is coming the concept of the maintenance, because who knows what all this clonal evolution is getting in that individual. But certainly you might see, it's not this, the slide, is this one, when you might see a decrease in terms of MRD, but anyway you do see a going up and down at the MRD level, and therefore this will be certainly a major issue in the future to control the disease, to achieve the cure, but certainly to prolong the outcome. Duration of CR. I completely agree with Sagar. This will be the next step, but, and the issue is, of course, do we have a biomarker of cure or not? And I have to play from this point of view or not, because these are the curves. These are all patients in MRD negativity. But you can see here that despite everything, relapse is arriving. And if you look at the longer follow-up, and I would like to give you some numbers. These are basically the same study. It's not really with carfilzomib, but this was a VTD study and thalidomide maintenance. So this was the limitation. But you can see here that at that point the CR could have been 50%, the molecular CR could be 25%, the duration of CR behind 6 years, 15%. But if you keep going with time, and here we are going to 10 years, at 10 years, this is the progression-free survival. And these were all MRD negative patients by PCR. So this was not just the immunofixation. So that's where I'm going, that if you keep looking at those patients and you really go to 10 years, so certainly you see a major improvement. Probably we are going to touch the 10 to 15 years. But I don't see, as in leukemia, you were already seeing a plateau early on, even in the absence of the novel agent. Then the Spanish have different studies, because this was, I was impressed by the Sagar study, because according always to Martin Lopez, in 2011, he found a major plateau with interferon. Now, this is just coming out from blood 2 weeks ago. Now, at the MRD level, I cannot see any plateau. So how comes that with interferon and no MRD definition, there is a major plateau for the cure? And here, with the evaluation of MRD positive, MRD negative, the plateau is gone. So closing with this slide, I would basically say, I don't think there is the evidence. I'm closing as I was starting from the beginning. I tend to think, I'm not sure, of course, that myeloma is very much like breast cancer. We will improve, we have improved, and we will further improve the outcome, but it's not like leukemia. This is a disease that probably, for what Munshi was saying before, is always evolving and relapsing. Maybe 15 years later, that at the end of the day, I would sign for. Thank you for the attention.